More than half the time a nurse tries to place a standard IV in a child, the first attempt fails. For adults, the failure rate reaches up to 26%. These routine procedures can quickly dissolve into chaotic, high-stakes scrambles at the bedside. I'm Brooke Wallace. Today on Super Nurse AI, we're looking at the hidden mechanics of vascular access and how to turn clinical uncertainty into a precise, calculated strategy. When the vein wall is breached, a burst pipe scenario occurs, extravasation or infiltration. Instead of flowing into the bloodstream, toxic medications or concentrated fluids escape the vessel and pull directly into the surrounding cellular tissue. Clinicians track the resulting damage using the NIR scale. A grade 4 infiltration is a localized disaster. The skin becomes stretched and tight. Deep pitting edema develops, meaning an indentation remains after you press the skin, and the tissue can begin to die, leading to necrosis and potentially permanent injury. Early detection depends on spotting subtle redness or swelling, but these signs are frequently masked in patients with darker skin tones. This allows the chemical damage to escalate silently before the clinical team even realizes the line has failed. Every shift brings unpredictable anatomical hurdles. Mastering these complications requires a move away from the blind stick approach toward a proactive, evidence-based framework that identifies risks before the needle even touches the skin. To objectively measure the difficulty of a vein search, hospitals use the DIVA score, which stands for Difficult Intravenous Access. The score assigns points based on physical markers. You get points if the vein is invisible to the eye, and another if it isn't palpable or bouncy to the touch. High risk factors, like an age under 12 months or a high BMI, also increase the score. A DIVA score of 3 or higher triggers an immediate change in strategy. It mandates a stop to all blind sticking, escalating the procedure to a vascular access specialist team equipped with high-frequency ultrasound. Using ultrasound, clinicians perform a compression test to tell a vein from an artery. When the probe pushes down, the vein, which has thin walls, will flatten completely. The artery remains round and continues to pulsate on the screen. Once the vein reopens, the metal needle enters the field. Because metal reflects sound waves, it appears as a bright white dot. Placing that dot directly in the center of the dark circle is known as the target sign, confirming the needle is perfectly positioned. Integrating the predictive data of the DIVA score with real-time sonar feedback removes the guesswork from the bedside. It allows the clinician to navigate complex anatomy with a high degree of objective accuracy. Getting inside the vein is only the first half of the battle. This diagram shows the catheter to vein ratio. For the vessel to stay healthy, the plastic tube should ideally take up only 1/3 of the space inside the vein. If the catheter is too large, it blocks the flow and creates friction against the vessel walls. This triggers an inflammatory response and leads to rapid thrombosis, or blood clotting, which can cause the IV to fail within days. Achieving the right placement involves high school geometry. To pierce the tough outer layers of the epidermis and dermis, the nurse must start at a steep 45-degree angle to reach the correct target depth efficiently. However, if that steep angle is maintained, the needle will puncture right through the bottom of the vessel, a mistake called backwalling. The moment the needle breaches the vein, the nurse must execute a flare, aggressively dropping the hand to 30 degrees to slide the catheter safely down the center of the pipe. Once the line is secure, the clinician begins the TLC protocol. Touch, look, and compare. They touch the site to ensure it's soft and warm, look for redness or kinking, and compare the limb's size and color to the opposite arm. A precise geometric entry is only successful if the catheter remains stable and the vessel stays clear. Securing the device and maintaining the TLC assessment cycle ensures the line remains functional and the patient stays safe throughout the therapy. Even with perfect technique, an IV can shift. If a TLC check reveals a cool, swollen arm, the threat has returned. A toxic chemical is now actively leaking into the patient's tissue. The response must be immediate. The nurse identifies the specific drug that has leaked and selects a rescue protocol tailored to that drug's unique chemical mechanism. For the vast majority of cancer chemotherapy drugs, the standard of care is the immediate application of cold compresses to the infiltration site. The cold physically constricts local blood vessels and slows down cellular metabolism. This traps the spilled drug in one small area, preventing the local cells from absorbing the poison and minimizing the overall injury. One major exception: vinca alkaloids. These plant-derived drugs physically bind inside human cells. Applying cold traps the poison. Instead, heat forces capillaries to dilate wide open, creating a rushing highway of blood that carries the drug away, diluting it safely throughout the body. Choosing between trapping a threat with cold or flushing it out with heat depends entirely on the drug's mechanism. Using targeted pharmacology in those first 2 hours is the only way to stop tissue death and save a patient's arm. Protecting your patients starts with understanding the why behind every procedure. I'm Brooke Wallace. Make sure to subscribe and visit supernurse.ai for more clinical insights. I'll see you at the next bedside.